let's wait for the people to gather around the live.
Okay. And let me share it. It is live now.
Okay. You know, in StreamYard, I can't see. I only see the slide now. You know that?
Yes, I know that. And we are seeing you, no problem.
Oh, okay, but I can't see. I only can see the slide.
No, I have seen that in the stream yet. As a guest, you can only see the slides.
Ah, yes. That's why I prefer Zoom. Zoom, you can see the slide and you can see yourself.
Inshallah, next time.
Inshallah. So just let me know when we are ready. Just tell me how you're doing in life in Bangladesh. I really miss the place.
Okay, we are doing fine. Inshallah, situation is getting somewhat in control.
You know you don't have curfew or anything from for the corona?
It has been slightly mobilized.
Yeah, you start to going out, of course, with the mask, with the surgical masks.
Yes, with the mask and safety precautions.
Because it's
Okay.
very crowded place.
Yes. I'm starting. One minute.
Okay, take your time. Just I will go get my coffee. Just a second.
No problem.
Okay. Are we ready there yet, Dr. Shams?
Okay, let me start. Assalamu alaikum everyone. A very warm welcome to you all to this beautiful and wonderful session. This is your host Dr. Samsudin Mahmood from Academy of Dental Professionals, ADP. ADP is a center for dental professionals to enhance their skills through continuous education and sharing of knowledge. ATP was established in 2016. Since then, it has been sharing its knowledge through various hands-on courses and seminars continuously. During this pandemic, ADP like to continue this continuous education through avenues. So we invited our guest, a renowned endodontist, Dr. Wael Sadek, to share his valuable knowledge. In short, Dr. Wael Sadek is a branch member of 3D Cleaning Project and a professional member of Global Outtake uh, Medical Association. And he also been a developer of SafeClean, a negative irrigation system, and a CareScope, a magnification system. So let me hand over to Dr. Wael Sadiq to present his webinar.
Hi, Dr. Shams. Am I live
You
now?
are ready to? Yes, you are live.
Okay. Hi, everyone. Thank you, Dr. Shams, for the presentation. We are going to talk about a very important subject that really annoy a lot of dentists, the post-operative pain. And we have to know that post-operative pain is nothing to worry about. It's mostly happened with any type or condition of the tooth you treat. It happened with simple pulpitis, reverse pulpitis, or with heavily necrotic tooth. It could happen with any tooth condition or any teeth you treat. What we're gonna talk about is how to make it less possible to happen with you, and what the reasons, to know the reasons, and we'll discuss how to avoid the reasons of post-operative pain, how to manage the post-operative pain if it happens, and the most important things, that how to differentiate between post-operative pain and its differential diagnosis, which is failure. You have to know that post-operative pain, however it is severe, or however the symptoms that could come with post-operative pain, like swellings, it's still temporary. The most characteristic parts of the post-operative pain, it is temporary, because a lot of dentists ask me they contact me and ask me that I have a patient that have severe post-operative pain for 3 weeks or for a month. No, post-operative pain is a temporary pain. It doesn't last for a long time. However, it is severe. It could be severe pain. It could have some swellings, but it's still a temporary. The main differential diagnosis between the post-operative pain and a real problem, which is could be failure or just a problem you can fix, is how long the post-operative pain is. In my clinical experience, from 3 days to maximum 1 week post-operative pain, and it has to withdraw. It's not constant. And I mean, when the post-operative pain start after the treatment, it's have to get better along the period, not to be constant or to be worse. That's how you can tell that it's a normal post-operative pain. There is no problem. You will do the management, how you can prescribe some analgesics or anti-inflammatory, or there's a problem. It could be fixed, or it will be a failure that needs retreatment. That's all what we're going to talk about in this lecture. Let's start with the definition of post-operative pain. As we said, it's a severe pain, could be with swelling after endodontic treatment. It could be after initiation of endodontic treatment, or after surgical root canal treatment, or after one phase of root canal treatment. It could happen after shaping. It could happen with intracanal medication. It could happen after obturation. It even could happen after final filling. If you do an obturation, you finish your root canal treatment and do obturation, and postpone the final filling for for another schedule. It could have you don't have any postoperative pain after obturation, and you have a postoperative pain after final filling. We will discuss that. So postoperative pain can happen after any step of root canal treatment. It's come in very different forms. Like it could be continuous pain, mild to severe. It could be pain on biting, and it even also could be a pain with stimulus. You can finish a root canal treatment, and the patient still got feeling with hot, cold, or sweet, and we will know why that happened. Okay. Of course, now it's very established that single visit endodontics is way much better than multiple visits. In my work, about maybe 80 to 90% of my root canal treatment is a single visit. What you need to do a single visit is better on the scientific wise, the outcome and the postoperative pain, even the patient, most of the patient prefer a very long one session, a single visit endodontics rather than multiple short visits of endodontics, because the situation of going to dentist is very stressful. To repeat the experience for one tooth for many times, it's not good for the patient. Nearly all my patients prefer a 1 hour visit than 20-minute 4 visits or 3 visits or even 2 visits. I can do it. I can open my mouth. I'm not feeling tired, but just get me the job done in a single visit. That's very good on the clinical wise. It will give you very good results. And also, as the research I shared with you in this slide, that said in its conclusion, you can search the title of the research. It's in the Journal of Endodontics, and you can read all the details of the methodology and the results. The single visit non-surgical endodontic treatment presented fewer incidents of postoperative pain in comparison with 2 visit non-surgical endodontic treatment. Also, in retreatment, the assessment ranged from 1 day to 1 month. That's one of the randomized clinical trials. That's the highest value of clinical trial of scientific experiments. So that's what you need is to make more single visit endodontics. So what you need to make single visit endodontics, that's a whole long lecture to do, but I will mention some points to help you to do single visit efficient single visit endodontics to reduce your postoperative pain. And also, every visit in endo, it's a loss on the financial side, on business side. You need to do a single visit is more beneficial for you money wise than multiple visits. This visits could be for a new patient that will pay a new fee. So you need to do a single visit to be more profitable, and also scientifically it's better. What you need is, one, you need a protocol. What I always said is you need to write down a protocol, to repeat it, and to have your hand familiar with it. I need a protocol for diagnosis, what tests I will do, you just write it down. The way I mastered my protocol, and I train my team to master this protocol, I write it down on a paper and I put it on the wall. When I examined my patient, I saw I looked at the paper, and then I said I will do the percussion test, I will do the air test, I will do the pulp testing, cold temperature pulp testing. I will do X-ray in straight view and in shifted view. I will let the patient bite down. I organize my tests, so I know I have a protocol for diagnosis. Then I will do my protocol for rubber dam. When I will do single isolation, when I do multiple isolation. I have a protocol for access cavity, what tool to do, what tool to use, and what step to do. I have a protocol for shaping. I have protocol even it's not always go straight forward, but even in surprises or in unfortunate event like a broken instrument, like I found a ledge, like I found a curved canal, I have a protocol for that. I have a protocol for any surprise I will found. Also, I write down the protocol for ledge bypass. I write down the protocol for broken instrument, for curved canals. I hang it on the wall. I always look at it. When you train yourself on a certain protocol, you will master it, and you will do it in less time. Now, if you see me working, and I will do live cases very soon, you will see how me and my team will take no time in changing an instrument. My team, and you have to have an assistant, a dental assistant. I can't imagine a modern dentistry without an assistant, because look, I am in a Bangladeshi I think page now. So I visited Bangladesh before. It's not different than Egypt. We're still a developing countries. We struggle here with prices, with techniques, with modern equipment that is very expensive, and we have the same struggles. But presence of assistant actually is beneficial for you financially. Some dentists work alone in their clinic. I can't imagine that. From day one in my clinic, I have a dental assistant. Having an assistant will make you more money. It's not a loss. Will give you good work, and you will have good infection control. It's beneficial from everything. Training your assistant on your work, on how. Also in Egypt, we don't have a school for assistants. No, we just bring any young lady and train it on the name of an instrument and the name of materials. It's have a lot of effort to train your assistant. I think you also. I don't know if Dr. Shams can correct me. If you have a school for dental assistant, Dr. Shams, you hear me? I can't see really. I only see the slide. But I don't know if you have a school for dental assistant, but here in Egypt, we don't. We train our assistant. Training your assistant is very important to do an efficient, fast work. So you have to have a protocol for every step, for every scenario. You have a well-trained assistant. And the only thing that will stop you from having single visits is two things. The only thing stop me from having a single visit is two things. One, the patient is getting tired. Some patients, they said what they can't do. Especially old patient, I don't recommend to do a single visit if you're gonna take a long time. If the patient get tired, he wave with I tell him, if you're getting tired or if you want to end the session, just raise your hand in a certain way, and I will finish my work. And after this, after you raise your hand with 5 minutes, I will finish my work. So if the patient get tired, I can do it in single visit. You can't push your patient, because what I always said is the patient comfort during treatment is as much as important as the quality of the treatment. If you do the best root canal treatment ever to your patient, but he feels pain, he feels uncomfortable, he getting tired, it's not only bad for business, because he will not do it again, because it was a bad experience, but it's also on the scientific way it's bad, because you have scientifically you have to make the dental visit a good experience to motivate the patient. This time he came with severe pain because he hates dentists, but he have a good experience. Next time he will come to you when he feels cold and hot. He will if he feels a good experience again, he will come the third time. He will come to you for just checkup without any pain. That's how you know the relationship between you and your patient is developing, because that's I have it firsthand. I opened my my clinic since 2009, about 11 years now, I think, 11 years. So I see how my relationship with my patients. He came if he came in severe pain, then he came when he feels cold, then he came for checkup, because he feels that it's easy to come to the dentist because he was comfortable. So number one, when what's make me don't do a single visit is the patient get tired. The second reason is I can't get a dry canal. That's happened when in mostly in necrotic teeth that you have with acute abscess. If you have an exudate or pus or blood that cannot stop in the same visit, you put intracanal medication and postpone to another visit. So there's only two reasons not to do single visits: if the patient gets tired, and if I can't have a dry canal. But to do a single visit, you have to have a protocol and to have a trained assistant. A protocol, a written down step by step for every phase of your endodontic treatment. You do every single root canal treatment in this protocol, so you can train yourself to be fast, to be efficient, to be familiar with the protocol, familiar with the steps. My assistant now, I have my assistant for about 5 years now. She can do assist me with her eye with her eye closed. She knows when I need the rotary, when I need the irrigation, when I need the obturation, because it's a repeated process. It's the same repeated process. I have a protocol. Sometimes, and that's what gives you what makes you develop, that you need to use a different technique, a new material. You can upgrade your protocol. Always upgrade protocol with a new equipment, with a new technique, but still you have to have a protocol, a written down, repeatable, scientifically based protocol. That's what will help you to do single visit that will benefit you financially and will benefit you on your in your treatment with reduced postoperative pain. Negative pressure irrigation versus positive pressure irrigation. Post pressure irrigation, what we know that it's using the needle and the side vented the syringe, and side vented needle, and the syringe is loaded with irrigant. You push the irrigant into the canal with positive pressure. That's what's called positive pressure. On the other side, negative pressure includes using suction to deliver irrigation inside the root canal system. That basically I'm using negative pressure for almost 10 years now. I developed a negative pressure irrigation device called Safe Clean. Negative pressure irrigation, it's very effective way and very safe way for delivering irrigant to root canal anatomy. And also one of the best characteristic of negative pressure irrigation is it's have you will have very low postoperative pain with negative pressure irrigation, because everybody know what is sodium hypochlorite accident is. Sodium hypochlorite accident, when sodium hypochlorite goes beyond apex to periodontal ligament and bone tissue. I think no endodontist no dentist using positive pressure won't have an experience a sodium hypochlorite accident. So sodium hypochlorite accident is a dose dependent, not a concentration dependent. That's the first point. It's a dose dependent, not a concentration dependent. What that mean? That means that sodium hypochlorite accident severity will depend on how much sodium hypochlorite go beyond apex, not what is the concentration. There is an experiment done on rats that they inject in the bone of the rats. They inject 4 milliliters of 5% sodium hypochlorite, and in the other rats they in the same rat, the other leg, they inject 4 milliliter of 2% sodium hypochlorite, and they compare the inflammation. The inflammation almost was the same. The healing period was almost the same. No significant difference between the two accidents, the two concentrations. The same amount, but two different concentrations. So what makes the sodium hypochlorite accident severity is how much sodium hypochlorite goes beyond apex, not what is the concentration. So postoperative pain could be a minor form of sodium hypochlorite accident. Postoperative pain could be because of 2 or 3 drops of sodium hypochlorite goes beyond apex during positive pressure. That's what caused postoperative, not causing the severe symptoms of sodium hypochlorite accident, but it caused postoperative pain because the damage that happened to just the periodontal ligament from the 2 drops that came out during positive irrigation. In negative pressure irrigation, on the contrary, you cannot go make the irrigant go beyond apex. It's nearly impossible to do that with negative pressure irrigation. So in the way to have less postoperative pain is to use negative pressure irrigation, and that's I experienced firsthand also, because I'm using negative pressure irrigation for 10 years with almost no postoperative pain. Almost, because there is another reasons, but for this reason, it's extrusion of irrigation sodium hypochlorite beyond apex. I don't have this problem with negative pressure. That's another research about negative pressure versus positive pressure that called that negative pressure causes less postoperative pain than positive pressure. Now let's go that also I want to stress on another point is the emergency visit. Patient came to you with severe pain. It's not scheduled in your clinic schedule. He wants an emergency visit. Some dentists just open the access, do pulpal tissue extirpation, and put a cotton with formicrysol, temporary filling, and that's how they do their emergency visit. I don't recommend that. It's good. It's have a 50-50 chance of relieving the pain or make the pain very severe, but it have more chance to make the next visit anesthesia is very difficult, because the formicrysol or the formaldehyde cause much irritation to the already irritant pulp tissue. It's not fixing. It could and it could fix. It could kill the pulp on the long run, but the patient will have even more severe pain than he came with in your clinic. So in emergency visit, I recommend to do access, take a working length, do pulp extirpation even with hand files. Don't do complete cleaning shaping if you don't have time. If you have, of course, do, but at least extirpation with 10, 15, and 20 hand file to full working length. Just remove the pulp. Remove the pulp tissue. Don't clean, don't disinfect, don't do anything, don't do even shaping. Just remove the pulp from the canal, not just from the pulp chamber. That will do more effectiveness, and you don't even need to do to put a formicrysol cotton, but just temporary filling. Just remove all the pulp tissue. You do access, remove pulp pulpal tissue from the pulp chamber. Take working length. Take working length with the apex locator, and then do some filing with 10, 15, and 20 hand file. Put temporary filling and dismiss the patient. But just remove all the pulp tissue, not just not just in the pulp chamber. Like pulpotomy, you do pulpotomy and do and put cotton with formicrysol. So I recommend to reduce the postoperative pain in the emergency visit. You have to completely extirpate the pulp from the root canal, not just from the pulp chamber. Now, intercanal indication. In intercanal indication, calcium hydroxide, non-sitting calcium hydroxide have a very bad reputation in intercanal indication regarding the postoperative pain. Most calcium hydroxide usually in most of the cases cause a severe postoperative pain. Now I have been using chlorhexidine gel as a intracanal medication for about 2 years now. 2 years now, I replaced calcium hydroxide with chlorhexidine gel. Almost all the modern research on the chlorhexidine gel as intracanal medication, it's very effective, even in some situation more effective than calcium hydroxide, and it's very biocompatible, very low cytotoxicity. Let's read some of the conclusions of this researches. Of course, it's less postoperative pain than calcium hydroxide, but also have many benefits, like it has a fast continuous action. It had a diffusion into the dentinal tubules and periapical tissues. It have a very good diffusion inside the dentinal tubules where the bacteria is present. Also, there's another finding here. Chlorhexidine provide 100% inhibition of microorganisms at the depth of 200 microns inside the dentinal tubules. Also, chlorhexidine had the ability to eliminate the endotoxin associated with the development of spontaneous pain, as you can read in the slides. Reduce the endotoxins come from the bacteria that cause the spontaneous pain. That's why it could be even eliminate post-operative pain if there was one. Chlorhexidine also broad spectrum, gram-negative and gram-positive antimicrobial. It eliminates the efficalis that is very resistant to sodium hypochlorite, and it's considered at 2%, which is the recommended concentration to be an intracanal medicament, is very cytotoxically safe. It's safe on the biological tissue or the normal tissue. One of my implantologist friend, it inject calcium hydroxide around the abutment when he screw the abutment into the implant to reduce the inflammation of the gingival bacteria and the food from mastication. So it's very, very biocompatible, and it's very low toxocytologically safe. Also, calcium hydroxide was less effective in reducing post-operative pain than the chlorhexidine gel. Also, there is what's called buffering effect of the dentine. The dentine is reducing the antimicrobial action of chlorhexidine by time. That didn't happen with chlorhexidine. Also, some clinicians combine the calcium hydroxide with chlorhexidine gel, but also in study that found that chlorhexidine alone is more effective in reducing bacterial culture than the chlorhexidine and calcium hydroxide combined. Now, also, calcium hydroxide and chlorhexidine, of course, the two is working by touching the bacteria. That when you do intracanal medication, the calcium hydroxide or any root canal, only intracanal medication must fill all the root canal, all the main canal, all the root canal anatomy. You have to fill it from apex to orifice. Calcium hydroxide is very radio opaque. When you do calcium hydroxide intracanal medication, it must, when take X-ray, it should be looks like obturation. It should be fill all the. If you do just coronal, because some clinician is afraid to have the calcium hydroxide outside beyond the apex, or goes beyond the apex, it will cause very severe apostomia. You cannot imagine the severity of the pain of calcium hydroxide beyond the apex. It's a very, very bad experience. If you have that, if you do calcium hydroxide and the patient has severe pain, bring the patient, don't give him anesthesia, just remove the pimple filling and wash with saline. Saline will completely remove the sodium the calcium hydroxide, and even push the saline beyond the apex to wash the calcium hydroxide beyond the apex, because that is what caused the problem. So what I mean is you have to fill the whole canal with the intracanal medication. with this requirement, it's very likely to have intercanal medication beyond apex. That is not a problem with chloroxidine. It's a very serious problem with calcium hydroxide, but it's not a problem with chloroxidine. So I push the chloroxidine and fill the canal, and I don't care if it's past the apex, because it's very biocompatible. It will not cause any postoperative pain, and now I'm sure that the canal is filled with the intercanal medication. The only what I said is disadvantage of chloroxidine gel that I use. I use chloroxidine gel from Cercamed. It's a Polish company. It's very good, very high quality, 2% chloroxidine gel. Don't have any radio opaque fillers. It will not show on radiograph like calcium hydroxide. That's one of its disadvantage. Also, you have to be very careful not to put chloroxidine gel on after sodium hypochlorite. If you finish your shaping and you will decide to do a chloroxidine gel intercanal medication, you have to wash very good the canal with saline and dry it, because of course everybody knows that chloroxidine and sodium hypochlorite don't mix. You shouldn't mix there or use these materials after each other, because there is a reaction happens, and it's the reaction byproduct is a participant that it's carcinogenic and could block the canal entirely. So when you want to put intracanal medication, a chloroxidine gel, you have to wash with saline before, very careful, very good wash with saline to eliminate any trace of sodium hypochlorite. And when you, in the next visit, when you remove the chloroxidine gel, you have to remove it with saline, and also wash very well with saline. If you're gonna use or you're gonna make an irrigation with sodium hypochlorite. So before putting in the before putting chloroxidine, wash carefully with saline to remove any excess of sodium hypochlorite. And in the next visit, you wash the chloroxidine with saline very carefully if you're gonna use sodium hypochlorite in this session. Okay, when I use calcium hydroxide, I'm still using calcium hydroxide. I use calcium hydroxide only on when there is an external root resorption. Because what is in calcium hydroxide that is not in chloroxidine is the high pH. The calcium hydroxide has a high pH. This pH, it's the reason that halts the resorption process in external root resorption. I need the low pH to stop the resorption process in external root resorption. If I have internal root resorption, I can good irrigation, good activation will kill any cells that cause. It will remove sodium hypochlorite, remove pulpal tissue, remove any cells cause the resorption internally in the internal root resorption. But in extra root resorption, the cell that causes the resorption is on the root surface from the outside. I can't get it with irrigation or with the sodium hypochlorite, of course. So I need the pH, the high pH of calcium hydroxide. That's the only condition now I use calcium hydroxide for. Now, also another cause of postoperative pain is sealer extrusion. What we call to be cool sealer buff. I hate sealer buff. Even some literature and some textbooks called sealer buff and procedure error. It's a mistake. It's not requiring, of course, correction or retreatment or apical surgery, but it's a mistake. It's like over instrumentation. Doesn't may not cause failure, but it's a mistake. It's a mistake. It's not a good thing, because some clinician, and I saw this firsthand, intentionally want a sealer buff. They push the sealer beyond apex intentionally. If you have a sealer buff, you should feel that it's an accident. I don't mean to get my sealer outside the root canal, because it's not a cool thing. It's not an indication for a good endodontics, or not an indication for anything. It's a procedure error. In my opinion, I hate sealer buffs. A lateral canal or a lateral failing anatomy, it's another thing. But just sealer outside the apex, it's not a good thing, because even if you use a resin or resin oxide ethanol or calcium hydroxide sealer, this sealer will resorb eventually, but it has a high chance of causing post-operative pain. Unlike bioceramic sealer, it's biocompatible and it's really to cause any problem, but still it's still it's a bad thing. Don't do sealer extrusion or what's called sealer buff. It's a procedure error. It's not a good thing to do. If it happens with you, you have to feel that it's wrong and it's not intentionally to be done. Sealer extrusion. Of course, what we're gonna do with sealer extrusion? Just wait and see. If there is a post-operative pain that is not temporarily, it's go beyond 1 week. It's not goes. It's getting better by the time there's a retreatment or, of course, apical surgery. But no, there is no post-operative pain for 3 weeks or for 1 month. It's not called a post-operative pain. It's a problem or a failure. Okay. That's another. It's of course bioceramic sealer do less post-operative pain than resin sealer, but as I said, sealer extrusion is the wrong thing. Okay, that's what I said. It's after only pulp extirpation, you have to remove all the pulp tissue from the all root all the canals, not just only the pulp extirpation as an emergency visit. After shaping, when there is a post-operative pain after shaping, even if you don't have intracanal medication, it's could be for over instrumentation. And I don't want you to panic from over instrumentation. What over instrumentation does is injure the periodontal ligament and bone, but it's just an injury. It's a normal injury. Think about implants. If you are worried, if you're worried that 2 millimeter or 4 millimeter of your file drilled into the bone, implant just drill in the bone intentionally. It doesn't. It's not a reason for failure. It causes post-operative pain, but it's just an injury. It's like a cut in your hand. It will heal. What's the really problem of oral instrumentation is losing the apical control. That when you do shaping, the tip size will shape the tip size of your rotary instrument will shape the apex. When you do open instrumentation, you lose your gauge. You don't know what is the gauge of the apex anymore. So that's a problem. If you lose apical control, or you don't know what the gauge of your apex, but the injury in the periodontal ligament and the bone will heal. It's just an injury. It will heal. Of course, we talk about irrigation extrusion in positive pressure irrigation. Missed anatomy could. It's very rare to, if you have a good root canal good shaping for all the canal. It's very rare that missed anatomy like MB2 or second distal cause the canal is alive. That it cause pain with hot and cold. Okay, pain with hot and cold. It could cause severe pain. Okay, but some clinicians also ask me if they do the shaping, they complete the shaping, and the patient still feel cold and hot or sweet sensation with the tooth. There's 2 reasons for that. A missed anatomy that is very rare to survive and to work. If a missed anatomy, if you missed anatomy with after shaping all the canals, it will the sodium hypochlorite irrigation and the instrumentation will just inflame the pulp inside the missed anatomy. It will cause severe pain, not just which will exacerbate with hot or cold, but not just like pulpitis or just irreversible pulpitis. It's very rare to do that to happen. What you have to think first is if there is another tooth beside this tooth have a cavity or have that's very common to have what's called the back-to-back cavities in the mesial of a tooth and the distal of the other tooth. that one is exposed and need endodontic treatment, and one is just causing pulpitis and reversible pulpitis and just a response to stimulus of hot and cold. You have to first think about that, not think about missed anatomy that cause a response to hot and cold. As I said, most commonly the missed anatomy will be inflamed and will cause a severe pain. You have to think if there is a stimulation, a normal stimulation with hot and cold, you have to think about another tooth first. It could go that, but it's very rare. Okay, after obturation. After obturation, the postoperative pain depends on the many factors. That's character, the duration, the intensity, signs and symptoms. Let's say that after obturation, what can cause a postoperative pain? Maybe filling material outside the beyond the apex, like what I said before earlier that you lose apical control. You push the cataperca outside that's why if I have to choose one radiograph to take in the whole root canal treatment, I will only take master cone. If I have to choose, if you have to choose one X-ray to do, preoperative, postoperative, master cone, obturation, what you choose to do, if you have one X-ray to do, I would choose master cone. Master cone is the most important X-ray in the whole root canal treatment process. So if you have the master cone, if you push your gataperca very hard inside the canal and take a radiograph, you will never have this error, because it will appear in your X-ray and you will cut it and you will adjust your cone, or you do MTA plug. You will avoid this error with the master cone X-ray. It's very important to have in every case master cone X-ray. Okay. So of course, after obturation could be a sealer buff, like we said, a resin sealer, or a sealer outside the apex could cause post-operative pain. What also is after obturation, if you don't use intercanal medication, if the root of the tooth is near to a vital structure like inferior canal or the floor of the sinus of the maxillary sinus, a sealer buff or a extrusion filling material could cause a severe pain that, as I said, not post-operative pain, severe to moderate, maybe with stimulation, maybe continuous, maybe like biting, like pain of biting, but it's still what is the most characteristic of post-operative pain. It's a temporary and getting better by time. Temporary and getting better by time. That's what it's characteristic of postoperative pain. Anything it's not getting better by time, it's stable or getting worse, and it's taking a long time, in my experience longer than 1 week, then there is a problem. It could be fixable, or it could be a failure of treatment and you need retreatment or surgical correction. So characteristics, duration, intensity, signs and symptoms. If there is a swelling with it's a bad sign if you have a swelling but it's not always a failure, but it could be exudate. And the difference between the swelling is exudate or just a pus generating. If you don't clean well, this pus will generate and go an abscess and swelling. Because if you hit someone in the face, punch someone in the face, in 2 minutes you will have a swelling. This is not pus. This an inflammatory reaction to the hit. It's an inflammatory reaction. So after shaping or after obturation, there could be an inflammatory reaction due to over instrumentation, due to inflammation of the pulp tissue that you removed, different things. So inflammatory reaction, it will go by time, as the punch and the position of the swelling will go better with time, or with just analgesics or some tampons, or it will go away. It's just an inflammation. So, but after obturation, you could have swelling. That could be inflammation, and you know that it's swelling just the day after obturation. It's very fast. It's not like abscess. It needs time to develop an abscess. If you do obturation and the swelling goes the next day, it's probably an inflammation. Okay. Now, with the worst thing that can happen is after post. As I said, if you have, if you finish your root canal treatment to obturation and you will do the final filling in the next visit, and you do the, there is no pain after obturation, the patient is good, everything is okay, and when you do the post and core, the patient feel pain, especially pain on biting. That's a very bad sign. That could indicate a fracture from a wrong side of the post, a wrong preparation of the thin. You put the post in a thin root. So pain after post insertion, which is includes postoperative pain, it's a very bad sign. Thank you, and I hope I could help. I'm open if you need any questions. Dr. Shams?
There are many questions. I'm giving you one by one. First question is, can you see?
No. Oh yeah, no. I removed that. I can see. Dr. Ahmed, Diane, what about devitalizing agent like? But look, what I consider, Dr. Ahmed, what I consider in what I'm considering in devitalizing agent, that it's the devitalizing process could be painful. The devitalizing process could be painful, and in long roots, I have a bad experience. In long roots, the devitalizing agent that you put in the pulp chamber could not reach the whole, could not devitalize the whole root, the whole canal. You will still have some inflamed, more, which could be more inflamed than the tissue that the patient came with you. I don't use any devitalizing agent. My emergency visit is access. Just searching for main canal, no extra canals if I have time, taking working length and shaping at least to 20 hand files to full working length, just to remove the bulk tissue. Is the chloroxidine comparable to effective calcium hydroxide? I think I shared the researches that said it's could be better. Chloroxidine is not radio opaque. The product I use and I know is not radio opaque. That's one of the disadvantage. But as I said, it's very biocompatible, so I push it until it fill all the canal, and may some go beyond the apex, but it had no effect. Do we need any special irrigation solution to completely remove the chlorox? No. Just good irrigation with forceful irrigation with saline, and chloroxidine also is, I think, it's hydrophilic. So if you leave it for a week, you actually will find the canal empty. The gel will go away. It happened at the solution for the gel. So you will find only just a trace of chloroxidine. It's very easy to remove. Chloroxidine reacts with. I think I mentioned this to Dr. Afrous Rakti. Help me with the names, please, Dr. Shams.
Afrous Rakti.
Yeah, I explained that you need to wash the canal very well with saline before using sodium hypochlorite. With saline, then use NaOCl. First use chloroxidine, then saline, then chloroxidine. That's right. He writes his name with Hindu. I can't read it.
No. That is Nasiruddin Hufaiza.
Yes. Huzaifa, yeah. I think I discussed this. Don't form carcinogenic products. That using chloroxidine with sodium hypochlorite will produce participants. So you need to wash with saline. What's your view on calcium hydroxide based sealer like Silepex? Look, I'm using resin and bioceramic sealer. Calcium hydroxide sealer is very good, and it's antibacterial and have a lot of properties, but what I consider my sealer is the dissolution. Zinc oxide digenol and calcium hydroxide sealer have a low dissolution power. It dissolves very quickly. You can see it if you have a buff after 3 days or even less than a week. You will see this buff go. That means the sealer inside the canal, if you have any lateral canal that it's not filled, it will go away. I don't like these sealers, the oxide general and calcium hydroxide, because it's they dissolve very fast. Resin sealer is resist dissolve the solution. Also, of course, bioceramic sealer is very it's a cement. I have follow-up cases with some sealer buff of bioceramic sealer for 1 year or 2 years and it doesn't disappear. So what I advise when you use bioceramic sealer, be careful not to have a buff, because it will not dissolve. It will take a very long time to dissolve. So if you have a buff on inferior alveolar canal or in the maxillary sinus or in any vital structures, it could cause a problem because it will not dissolve. So I don't use calcium hydroxide or zinc oxide additional sealer for that reason. Tell something on calcified canal management. Look, calcified canal management, that's a very long topic. Inshallah, we'll do it with Dr. Shams sometimes later. Which sealer material is the best for root? There's no such a best anything. There's no best file. There's no best root canal filling material. There is no best composite. There is no best bond. What suits you makes you what is cost effective for you. If you ask me what is the best car, I will tell you Lamborghini. I can't afford Lamborghini. What the question is what is the best car I can buy, because some of course cost comes firsthand in every aspect of our life. So if you I'm running a moderate dental clinic, I can't use fancy things, but I use the best thing I can afford, the best thing that I can afford for my patients. So the best sealer material for you is the best thing the best sealer you can afford with your cost. How many should put chloroxidine? You can put it for 10 days to 2 weeks. 10 days to 2 weeks. 1 week also in moderate infection is very good, but the least amount of days you can put chloroxidine is 1 week. I think I got it all the questions.
One question from my side.
Of course.
Yeah, what is the precaution to have during obturation with bioceramic sealers? What precaution should we take for sealing with bioceramic sealers?
There is 2 ways of obturation with bioceramic sealer. There is an injection way, when you inject the sealer directly into the root canal, or into the root canal orifice, and then you coat the cone with bioceramic sealer and insert in the canal. Okay, and the other way is to just coat the cone with bioceramic sealer and do 2 to 3 washes. What is wash? I coat the cone with bioceramic sealer, put it into canal, go clockwise, anti-clockwise, and out. Another wash, put it in the canal, go clockwise. When I take it from the canal, go anti-clockwise. Another wash, 2 to 3 washes. I recommend the injection way with magnification, so you can see where the needle is going, where it is snug. The injection way goes where you push the needle as far as it can go. When you feel it's snug in the canal, you get out 2 millimeters, 2 to 3 millimeters, so you can make room for the excess of the sealer to come out to in orifice direction, not in apical direction. If you snug the needle and push the sealer inside the canal, it will go in the apical direction, and you have high chance to get the sealer outside beyond the apex. So you insert the needle to the resistant point, you go back 2 to 3 millimeters, and then inject. So the sealer will go into the orifice direction. It will have room around the tip, so it will go in the orifice direction. I recommend this way in people with magnification, with at least loops, so they can see what they're doing. If you don't have magnification, it's better to have the wash way. It's okay, Dr. Shams?
Thank you for your valuable knowledge sharing, and we will like to see you again in future, inshallah.
Of course, dear friend. Thank you for having me, and stay safe.
Stay safe also.
Thank you.
Okay. Thank you all for hearing our webinar. We will be hosting this webinar in futures, inshallah. Thank you for joining us. Thank you all. Assalamu alaikum. Goodbye, everyone.
Waalaikumsalam.